Welcome to APTA Orthopedics Orthostatic. Today, we have a fantastic guest whose dedication and expertise have made significant strides in the world of pediatric physical therapy. With over 16 years of experience at the renowned Cincinnati Children's Hospital Medical Center, she's not only a physical therapist there, but also the primary therapist in their interdisciplinary pain clinic, specializing in treating pediatric patients with musculoskeletal pain. Today, we're looking into the intricate world of pain and pain-focused clinical practice. We'll explore what pain is and why it's such a complex experience. We'll discuss the biopsychosocial model and its importance in understanding pain and uncovering how psychological, emotional, and social factors influence pain perception. Let's bring in our guest, Dr. Nancy Durban. Nancy, welcome to the show.
Thank you. Thank you for having me.
Well, let's dive into this first. Can you explain what pain is? It's no small feat, and why it's such a complex experience.
Yeah, that's a great question. And I love to start anything off by talking about pain and the definition of pain. And, it is deep. So when we start talking about pain and the definition, it's very comprehensive. So it is deep. The gold standard of the definition is set forth by the association, the IASP. It's the International Association for this study of pain, and they do have the gold standard. So I'm going to actually read this gold standard of pain, so I have it out there in the world. It's an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And so that is the gold standard definition. But they put forward, along with this definition, it's great. They have 6 different keynotes that go along with this definition to help us better understand a patient's experience, that it's not just the science, it's not just the biology of the pain, that they're bringing in the psychosocial components of the pain. So pain is always personal. It's always a personal experience that's influenced by these different variables, the biology, the psychological, and the social factors of the person. So that's the first keynote there. The second one is that pain and nociception are different phenomenons. Yes. So the nociception is the activity of the nociceptive receptors, and the pain is the perception. So they're different. They're different entities, and we have to remember, that. And then also, this is a great key point here, that through life experiences, individuals learn the concept of pain. And I love hanging my hat on that, because if something's learned, then we know we can help somebody unlearn that or learn something different. So I love the fact that, they're identifying that it's a learned concept. And then that a person's report of an experience as pain should be respected. And we do. We need to, as professionals, respect that a patient, may come into the clinic and be all very well put together, smiling, laughing, and reporting that they have pain. And, you're human. You're thinking, are they really having pain? You have to respect. Yes, it's the personal experience. They are having pain. And then the fourth point is, or the fifth point actually, is that although pain usually serves as an adaptive role, it may have adverse effects on function and social and psychological well-being. So that's tying that all, together. Again, one influences the other influences our experiences. So, and then the verbal description is only one of several behaviors to express pain. So those visual analog scales are not the only scales, and that people who can't communicate verbally still need to be able to be assessed and addressed and understood, that they are having pain. So I love that, that's a big definition.
Sure.
It's deep. It goes beyond the science. It brings in that psychosocial, component of it, which is so important because it isn't just the biology or the science within our body of how pain is produced.
All right, well, Nancy, at least we got the easy question out of the way first, right? Just give you the fastball right out of the gate. Let's zoom in a little bit on that. You mentioned a couple different words there: psychological, emotional, and social. So how do those three, psychological, emotional, and social factors, influence pain perception?
Yes, so they are all interrelated, and it's interesting to think about. You can't just think about one component separately. So our thoughts, our emotions, our feelings, and our moods kind of set our being of how our presentation and how we act or work in the world, right? So our thoughts are our perceptions of a stimulus or a trigger, and then those thoughts then can trigger the emotions. So you then have thoughts and emotions, and you can see how there's that interrelationship. Now the emotions then will release chemicals, and those chemicals in our body then are there to for a while. So our thoughts are just kind of fleeting. The emotions then stay around a little bit longer, and then those chemicals then cause us to have certain feelings. And then the feelings that we have and the mood set the mood because we're thinking more about it. And you can see how those are all interconnected. The thoughts, the emotions, the feelings, the mood, and it sets the mood of the patient. The mood then would be, okay, am I in a happy mood? I mean, it could be good, right? All of those could be great and produce good chemicals and happy chemicals that are released. But then we can have, the other side of it where it's the darker side and, being, more, having more anxiety and depression and, how those chemicals then also can be released. When I talk to my little patients about how this is all interrelated, I talk about, these nosy neighbors in the brain. And we've got this community of different centers in our brain. And the house of pain is right next door to that house of anxiety. And the house of anxiety kind of is like a nosy little neighbor that when the lights are on in that house of pain, the beings in the house of anxiety kind of like look out and peek, and they're like, hey, they're having a party, let's go party. And so then there's a big party in the brain about that's where all the lights are lit up on that particular street in the community of the brain. So they're housed all right next to each other, so there's so much of an interconnection. And then also when we think about that release, the emotions that release the chemicals, it's a chemical change then within the brain that can set you up. You think about anxiety. When we're anxious, we're in that state of fight or flight. And if our body is constantly in that state of fight or flight, then our nerves are pre-sensitized to any kind of little trigger or emotion. Anything could then trigger those nerves to do a all or none response, and it's very hard to then relax or get those muscles to then do what we want them to do because they're just so ready to fight or flight. So that's how kind of it's all really so interconnected.
Yeah, very visual. It's easy to see that when you're giving the various houses example and how those ideas might jump around, and people can picture that. Let's move on to something that we've talked about before on this program, but I want to hear your take. What is that biopsychosocial model? So we've talked about those things, right? We brought in a couple of those words already: psychological, emotional, social. But let's talk about this model, the biopsychosocial model, and why is it important in understanding pain? Let's bring that into it.
Okay, so pain is one side of that coin of the biopsychosocial model. We look at it as on the opposite side, it could be the model of health and wellness. So when we look at it with a focus or a lens of pain, it is that something has gone wrong in each of those. It could be each, it could be a concentration in one component versus the other. But I think as physical therapists and physical therapist assistants, we have in the past done a really good job at the bio. Our education has been, more on that bio of the biopsychosocial model. But, they are all linked. And I feel as we, it's the tides are shifting, that we're looking more at that psychosocial component of the entire person and treating the whole person. And I believe, kind of my little mantra is that, it's not just a tissue issue. It's not just biology. To treat the whole patient, you have to consider the psychosocial components and influences, because they're so important. And if we don't, we're doing a disservice to the patients because we're not treating the entire patient.
Well, let's do a little bit of history. Even in just the last few years, I feel like the understanding of pain has evolved with this model, and especially within our profession of physical therapy. How's that happened from your point of view? How has that understanding of pain evolved?
Oh my goodness, I love in the clinic. I've been practicing in this particular clinic now, 16, 17, 18 years, I think now. And the talk has really changed. People are not just looking, have their blinders on and looking at, how much force can someone produce.
Sure.
That's truly important. The way someone moves is important because it can contribute then to pain and continuing to have pain. And if we don't address that, that's true. We're not addressing that component of the patient, but really concentrating more and listening more. I see our evaluations having components of where physical therapists are asking, how did you sleep last night? Tell me about your sleep. Tell me about your hydration. Tell me about your mood. So they're really bringing all of those other factors into their evaluations. I teach at the University of Cincinnati, the graduate PT program there. And my mantra to them is, you always, assess and address. So if you don't identify or even ask, then you can't, again, treat the whole patient. So it's assessing and addressing. And you may not be the person that can address everything, and that's fine. But if you assess it and identify it, then you have to address it.
Yeah, well said. Let's move on to pain management. You work in this area pretty extensively. How do you approach pain management in a pain-focused setting, in a pain-focused clinic?
Well, it's kind of interesting because we try to not focus on pain. So that's how we treat patients. We don't focus on pain. We change the focus, actually. It's interesting. The saying in the interdisciplinary pain clinic where I work is, the function returns before the pain goes away. And you know what? We may not be looking at complete pain relief, but we're looking at what level of pain or what level of discomfort can someone function at or with. So it's maybe not, completely getting rid of someone's pain. And that's really actually a hard concept, and especially at a pediatric facility, because parents bring their kids in and they're like, I don't want my child to have pain. And no one does. But it's more about function and allowing them to return to what they love to do, what brings them joy. I feel like a lot of times people get so wrapped up into their pain and their symptoms, and that they really like lose fact and lose focus of who the person is. They're not just their pain. They're not just their inability to do something. There is a person there. So looking at function returns before the pain goes away. And the way that we approach that is, it's a graded approach. We, as the physical therapists, we are the movement experts. So we're the ones who are trying to get the patient moving however they can, because we know movement is medicine. If we get somebody to a point where they can actually release their own pain chemicals that are in the body that reduce pain, it's great. Those endorphins and enkephalins, because if you're taking medicine, you're taking chemicals to reduce the pain. If you can exercise enough that you're releasing your body's own pain suppressants and resetting those nerves, that's such a more holistic and well way to do it. So it's little steps. It's graded. It is trying to get someone moving without producing or provoking a pain response. I like to look at a little analogy that I use as a traffic light.
Okay.
So I come in, the patient comes in, and I'll be saying, so how are you feeling today? Kind of overall, how is your mood? How is that influencing how you're feeling? But they'll say, oh, I'm yellow, meaning that caution. They're in that yellow zone of the traffic light. If they're saying they're green, okay, they are like good to go, and they are flourishing, and they are ready to go. And then we'll exercise. We'll do the functional exercises in a graded approach, in a safe and controlled environment, which is super important, because they need to know that they're safe to explore movement. They may not move the same way that other people move, but that's okay, because everybody else in this clinic is not moving the right way, maybe either. So having them explore how to move safely, but also to be in control. And that's all about the amygdala, that safety and control issue, and communicating with the patient, helping them, get through that. I'm safe, I'm in control, let's explore movement. Let's not provoke that pain response. If we do, it's okay. We've crossed that line between, what's enough, what's too much. Let's regroup. Let's figure out, if you're in that yellow zone, that caution zone, let's bring in those cognitive behavioral therapy skills that you're learning. Do you need to take a break? Do you need to take a breath? Do you need to sit down? Do you need a drink of water? Do we need to be mindful of, what are we experiencing at this moment as to why I've gone from green to yellow, or I'm yellow to, oops, I'm getting into that orange, red zone. What do I need to do to get myself back? And that's the other key too. It's self-management, giving them the skills to practice in that safe and controlled environment on, practicing how they can then, manage their own pain.
Well, let's get more specific for clinicians. Could you share some examples of how maybe a personalized treatment plan is actually developed? Is there like a framework you work from, or something that the audience could understand?
A framework. So I, will start out. The first thing I do is, I do a little check-in. So we start with, kind of that mindfulness. Where are we today? What have you done? Because I want to celebrate, their accomplishments. So you absolutely like to do that. motivational interviewing is huge. So
Yeah.
I will, actually, do that check-in. How are we with accomplishing that goal that you want to accomplish? Because if we can't make our physical therapy or what we're doing in the clinic meaningful to accomplishing their goal, then they're not going to have buy-in. And especially, I was thinking about this too. I mean, kids, a lot of times I will say, why are you here? Like, because, my parents brought me, or, and then I was thinking, okay, well, that's not so far-fetched with adults too, because they may say, oh, the doctor just told me to come, right?
Right.
So again, that patient gets lost in, pain and how they're functioning and perceived. So I want to kind of get down to those layers and ask them, what's important to you? What brings you joy? Let's, look at those activities. Let's, divide those up. And so that's a lot of work outside of, when I'm documenting, and, planning for the next session. So, I then break up those goals that they want to accomplish into, smaller steps, into what exercise, what movement, their endurance, all of those kinds of factors that would factor into them being able to accomplish. So again, it's that graded approach, small. Do I start out with them doing 30 repetitions of an exercise? No, we can do lots of different exercises that work the same muscle in different ways. So I vary it up again, but grade it so that at the end of the session, when I check in, I say, okay, do you feel like your muscles have worked? And, if they're like, yes, I feel my muscles have worked, great. And I'll check in with them throughout the session to make sure that we have a lot of kids that are hypermobile and actually then have more joint pain than muscle pain. So I'm constantly checking in, with them during the session. How is this feeling on your body? I'm not asking about pain. How is this feeling? And, if they're saying, oops, it's right in my knee that I'm feeling this, then we switch. We put them in a different position again. But the goal is, my mantra, movement is medicine, function comes before pain goes away. So, getting them to move and a graded approach. And then, also those check-ins are, checking, are you green, yellow, red? And then bringing in the psychological component to it. What do we need to do to get you into those other, zones? There sometimes are times when they're like, I'm done. And I have a little friend who emotionally dysregulates. And when he is done, he is done. But we talk and we plan then, what he can maybe do at home, or when does he feel he's going to be ready to either move again today, or, what are you going to do at home then? So it's all about trying to really read the patient. It's so interactive. I feel like, multitasking, and, purposefully switching my attention from when, I'm trying to do a little documentation of what's going on during, the session. But, the main focus is giving my attention to that patient that entire time that they're there, to give them the best experience and keep them moving and in a safe and in controlled environment.
Well, you just almost gave me a little segue into my next question with that example about your friend who knows when they're done, they're done. How else might you integrate psychological and emotional support into your treatment as a physical therapist? That's one good example you just mentioned. Is there another, or how else would you answer that?
Yes. So it's definitely different with each child and with each person, because each person, again, it's their own pain experience. And, I am not sure what the trigger is, but we've got to communicate as best we can, because I may not know that this little person, as soon as I say, let's work on balance, that he is like, balance means nothing. I don't want to work on balance. So, asking him a little bit more about what are your, have you identified triggers, so that I know, so I can stay away from that. I do a lot of calling our psychologists to find out exactly where they are. They do a lot of the cognitive behavioral therapy treatment that is a 6-week program, and they look at different skills that the child or that somebody else is learning, and so I need to know where they are in that, and how that is affecting their descending inhibition and their ability to kind of calm themselves down and be able to get into that yellow or green zone. So working with the psychologist and finding out, what's going on. But also, the parent helps as well. There may be a lot of other environmental things that we have no idea about. There's a lot that these kids get exposed to that is not good. And trauma, trying to, calm someone down so that they can regulate their emotions and they can focus on themselves is super important. And I think that, that is a great place where, physical therapists are doing a lot better at understanding, trauma care, and that emotional, component, and how we can help, and not just say, oh, okay, and just kind of move on. Again, you're identifying it. You've got to assess it and address it.
Great. All right. Last thing we do on this show is called Words of Wisdom. Is there a phrase, a saying, an idea, a mic drop moment, a soapbox statement that you share? Usually people like yourself who do wind up teaching have these sort of sentiments. What would you want to leave with the audience today as we wrap up?
Oh, gosh. I think I've already said mine.
You can repeat. It's okay.
All right. It's not just a tissue issue. And if we don't look at the entire person, we're not treating the whole person. That mantra that function returns before pain goes away. And movement is medicine. No matter how we can get somebody to move, we need to get them to move. And especially, people, screen time. I love the new saying, green time instead of screen time.
Yeah.
So, getting people to move.
Well said. Nancy Durban, thanks so much for dropping by and imparting some knowledge today.
You're welcome. Thank you for the opportunity.